Welcome everyone to the first of the workshops series at our Center of Excellence for Infant and Early Childhood Mental Health Consultation conference, Equity from the Start. I'm Deborah Perry, a Director of Research and Evaluation Efforts at the Center for Excellence. And I'm so delighted to be joined by three speakers who are going to talk about the work that has been done in Ohio. I would like to introduce Dr. Valerie Alloy. She's the Chief of the Bureau of Grants Administration for the Ohio Department of Mental Health and Addiction Services. We also have Lisa Golden, who's the Infant and Early Childhood Mental Health Administrator for the Ohio Department of Mental Health and Addiction Services. And we also have Dr. Maureen Black, also with the Ohio Department of Mental Health and Addiction Services, who's the Infant and Early Childhood Mental Health Workforce Development Consultant. They are going to have a lot of content to share, and I know we want to get right to it. So without further ado, I'm going to turn it over to Lisa.
Thank you, Deb, and good afternoon, everyone. We would like to take the opportunity to welcome you to our session, Ohio's Infant and Early Childhood Mental Health Consultation Journey, Building Statewide IECMH Consultation Model from Logic to Outcomes. We are coming to you from the great state of Ohio, where our Governor Mike DeWine, is our leader, along with Director Lori Chris with the Ohio Department of Mental Health and Addiction Services. We are so excited to share with you today how Ohio is working to eliminate disparities with the children and families that we serve through our intentional partnerships and programming. Again, you are joining us today with myself, along with our former Infant and Early Childhood Mental Health Consultation Administrator, Valerie Alloy, and our Workforce Development Consultant. Today, you will hear all three of our voices as we share Ohio's journey. And with that, I will start our PowerPoint and turn the microphone over to Dr. Valerie Alloy.
Good afternoon. Thank you so much, Lisa and Dr. Perry, for the wonderful set of introductions to the Ohio presentation today. It is my pleasure, next slide, please, to share our journey from logic to outcomes, Ohio's journey. I like to put this image up as a grounding slide because it really echoes the comments that Dr. Neil Horn made in the conference introduction. I think this really illustrates all of it. Of course, equity from the start, inclusion. I think the image also talks to the goals of grow, advance, and impact. We want to grow healthy children. We want to advance systems at all levels, individual, family, and community. And we want to achieve impact during our lifetime and across the lifetimes of all the people that we are here to serve. So I like us to start our presentation with a little grounding and a very powerful image. Happy, healthy children, happy, healthy citizens, systems, and families. Thank you. So Ohio's journey started on the shoulders of our wonderful ancestors and visionaries who really opened up the door to the need for this specialty starting over 44 years ago. And I did the calculation just to get a grasp on it myself. We have the 1965 legislation that brought our Head Start community into play. We know that Head Start really ushered in the infant early childhood mental health specialty. We also know that we had our first monograph published by our founders, Kaplan, Cohen, and Kaufman, which we all should know this preliminary slide. We had the work followed up by our wonderful colleague and friend and partner in this work, Dr. Walter Gilliam, and we'll hear more from him in Ohio's journey soon. We have the SAMHSA launch of Project Launch, which really began to pay for and support very programmatic levels of infant early childhood mental health consultation. And of course, the famed study out of our partners at Georgetown, What Works, a nationwide study of quality infant early childhood mental health. So these 44 years are the foundation that all of us should know and understand in this wonderful specialty. Ohio's journey then continues when we established our first credential in 2009. Shortly after that, we were a part of the Early Learning Challenge states, and that really gave us our lift. As a part of the Race to the Top community, Ohio had 16 early childhood mental health consultants as a part of a statewide professional development network. At that time, we were doing training around our state through our 16 state support team regions. That's how all the professional development was configured. And remember, there were many, many goals to eliminate disparities in President Obama's Early Learning Challenge grant opportunity, and Ohio truly benefited from it. At that time, I was asked, we were spending about $1 million in our space, and I was asked, was there anything more we felt we could do? And even then in 2013, I knew that we could double, triple, quadruple the number of boots on the ground in our specialty. And then soon after that, that message was heard at our governor's office, and Governor Kasich then launched the Ohio Whole Child Matters Initiative to improve access to early childhood mental health consultation and reduce disparities in expulsion. And honestly, the program was designed as a preschool expulsion, I'll call it an intervention or measure. And that was the goal. But I will say that when asked to develop this program, I was very willing to see us stand up a program that addressed expulsion, because we all know from the data that African-American children, particularly boys, are at the higher end of this expulsion disparity window. And I knew that that was important to do. But I'll say this now, as I've said many times, I didn't want to just build a program that prevented expulsion. I like to say that just put fire out, because all you'll ever do is run around and put fires out. I promised to build a model that would lift social emotional wellness for all children. And in my language, that's prevent fire. I wanted to build a model that prevented crises, that prevented fire, that prevented expulsion. And by so doing, expulsion would become an outlier in our data set. And in our later slides, we're thrilled to show you what we've been able to do with that type of operating premise. We also knew it was important to have tools. People learn and communicate, and as you think about the development of your early childhood mental health programs, I really want you to rely on your state partners in other states who have developed toolkits. Our health department launched something called the Oh Baby Toolkit. And that Oh Baby Toolkit is a mass media approach, printed materials and other things that help families, caregivers, educators, and children look at development in a healthy way. That began a very healthy competition, and our two state agencies battled it out for the next set of toolkits. Ohio developed the Grow Power Toolkit. They redid the Oh Baby Toolkit, and then Ohio launched the You Are Loved Toolkit. And all of these things are available on our State Department website to help give you more information. But these tools to the field, tangible tools to the field, are very important in your journey in the development of your program. We take great pride in this slide, and I want us to resonate on it for a moment. We never dreamed that we would reach the attention of the White House. But in 2016, Ohio, along with several other states, were featured in the White House My Brother's Keepers 2016 Progress Report, which really talked about the outcomes of the Early Learning Challenge grant, but also reported on our efforts to close the disparity gaps and raise equity in the early childhood and across the lifespan space. So Ohio is featured in the My Brother's Keepers report, and that is definitely a moment of a deep pride for our state. In 2020, we established our infant mental health credential. That is an important growth point in Ohio's journey as well, because it was an opportunity for us to look at what was happening on the national landscape, We were aware of the emphasis on infant care and infant mental health, but Ohio didn't have anything that was particularly focused in that area. We looked heavily at the Alliance model, which is still the golden standard for infant mental health, and Ohio chose to develop its own credential in this space. So in 2020, Governor DeWine's Office of Children's Initiative launched the Ohio Infant Mental Health Credential. This is a cross-disciplinary credential that allows us to integrate best practices to promote improved collaboration that will drive our infant mental health wellness outcomes across our home visitors, across our early intervention, our education, our job and family and child care professionals, and our mental health professionals. And Dr. Black will talk more about the Ohio Infant Mental Health Credential later. We also culminate a very important time in our timeline in 2020, when our partners at Yale conducted the first ever randomized controlled trial study of infant early childhood mental health consultation in the state of Ohio. This is now published in a peer-reviewed journal and is really a foundational, seminal moment in our field, because it will begin to pave the way for us to be recognized, our practice, our specialty, to be recognized as an evidence-based practice. We have a few slides on the results of that study conducted by Dr. Chen Reyes and Dr. Walter Gilliam, but we are thrilled that that was completed in the state of Ohio. And it appears in the Journal of Developmental Psychology, as noted in the footnote there, published in 2021. And it was called Addressing Challenging Behaviors in Challenging Environments, Findings from Ohio's Study. A few other highlights in Ohio's journey. This year, the 2022 biennium has shown Ohio having the largest investment that we have seen yet in our specialty. Over this biennium, Ohio will be investing, this is current, over $17 million in our infant early childhood mental health program statewide. And that extra lift has occurred through our dynamic partnerships. Our foundational partnership was the Department of Job and Family Services. We also then next expanded to the Department of Developmental Disabilities, who wanted our specialty available in each of the EI areas. And there are 88 counties in Ohio, and we have early childhood mental health consultation available in each of the 88 counties. And then this year, we have a new partnership with the Ohio Department of Education, looking to expand consultation in each of their 16 state support team regions. So we are just thrilled that we are offering and partnering in these ways, in very dynamic and important ways. And finally, we are doing a major footprint expansion in pediatric primary care as a result of our COVID-19 dollars. So that is just a highlight of our journey. And I believe there is the next slide that Lisa Golden, our new Infant Early Childhood Mental Health State Administrator, will take over.
Thank you, Dr. Alloy. And so what you are looking at right now is an image of Ohio. This is actually a map from our interactive locator on our Ohio Department of Mental Health and Addictions Services website. And it gives you a chance to see the types of partnerships that we have created throughout the state. Just some little pieces about Ohio. Ohio is the 7th populated state in the country with approximately 11.8 million people. The Ohio landscape consists of urban communities, rural and Appalachian communities across those 88 counties that Dr. Alloy identified. We have 3 large urban areas in Cleveland, Columbus, and Cincinnati. Throughout the state, we have over 8,000 licensed center-based childcare programs, preschool programs, and family-based care settings. And we strive to provide our services across all of those settings. We're able to create access and opportunities to support the diverse needs of the families and the children in Ohio through our strategic partnerships across the state. As you see, our partners include local boards of mental health, We include our community behavioral health partners. We consider our educational service centers as a key partner, hospital systems, and child care resource and referral agencies. It is through these strategic and intentional partnerships that we are able to bring our services to communities that may not have the opportunity to have these types of services available. We know that infant and early childhood mental health is a very unique skill set. And so we want to make sure that we have those available to all of the families in Ohio. So through this, we're able to deliver our services. Here we have our Ohio Infant and Early Childhood Mental Health Model of Service Delivery. And we really describe our services in 4 buckets or 4 program components. That first program component being our workforce expansion. And when we consider workforce expansion, we know it is important to continue the early childhood mental health consultation to the early childhood field and being able to provide those consultants in those care settings. We do this through our ongoing work to support the development of the field and promoting the early childhood infant mental health credential that we will talk about later. Next, we have our training institute. And our training institute consists of a cohort of trainers who are skilled at providing training topics across the early childhood and early childhood mental health topic areas. Those individuals provide trainings not only to the field, to those teachers and early childhood professionals, but they also provide trainings to our early childhood mental health consultants on the evidence-based tools that we use in Ohio to allow the consultants to keep up to date in those tools, as well as maintain those credentials. Next, we have our Ohio Preschool Expulsion Prevention Partnership. And this is Ohio's effort to prevent the expulsion of young children by creating a safety net for programs who are experiencing a challenge with a child in their program, and they don't have the access to an ongoing early childhood mental health consultant. So this safety net allows for programs in any of those care settings to call a hotline and get access to brief consultation within 48 to 72 hours and be able to get those tips and strategies and tools in order to maintain that child in their care setting. Finally, we have our statewide program evaluation. And this is one of our most critical components to the service model. In Ohio, we have an infant and early childhood mental health centralized database system that holds almost 10 years of data regarding individual children and classrooms. We use this information to not only inform our practice, but we have an external evaluator that examines this information and provides ongoing reporting to identify the statistically significant impact our program continues to make year after year. And we're so excited we get to share a sample of that data with you later in the presentation. Dr. Alley will walk through some of our slides that highlight some of those pieces of information. Next, we're going to look at our logic models. And these logic models are created to inform the work that we do. They were created through a consultation process with national experts in the field, many of which are joined with us today. Through that process, we have identified 4 programmatic areas of impact. However, we will focus on just 3 for today's conversation. Our first logic model that we want to cover is our classroom focused logic model. In this logic model, you will see that we have our goals. I want to draw your attention to the orientation of the logic model. We have our goals at the top. We then also identify our population that we are targeting. And we also want to acknowledge those external influences that really do impact the work that we do. The next portion of the page covers our resources, activities, outputs, and our short-term and long-term outcomes. And so when we look at this classroom-focused logic model, we are looking at how do we help support and promote healthy social and emotional development and school readiness. And we want to build capacity of teachers, parents, and caregivers. Our population. For us, it's important that our services support all families, and especially those programs serving families who are considered to be at risk, as well as serving families and children who are at risk for developing a developmental delay. When we consider some of those external influences, that those factors that impact our work. We know that funding can be a limitation. We know that there are workforce concerns. And while not indicated on this model, we certainly know that we will have to consider the ongoing impact of the pandemic as we look at how our work is impacted. Next, we look at our resources, activities, and outputs. Our resources really are the team. It's those that come to do the work, the consultants, it's the teachers, it's the parents, it's really the who that we work with, as well as some of the information and resources that we bring into this consultation relationship. Next, we have our activities, and that's really the what. What are we doing? Those observations, the consultations, those trainings, the information, the coaching, all of those aspects that we do each day. Next, we have our output. And so that really is the data, the numbers that really identify the work that documents the work that's being completed. And then we have our short and our long-term outcomes. And I just want to highlight a few of those short-term and long-term outcomes. And we're thinking about how we focus our work, and we think about what are the things we're striving for. When we're looking at our classroom focus outcomes, we really are looking at how do we enhance and support fidelity across programs. We also want to help children and teachers experience the joy that comes in their classroom when behaviors decrease and those skills, those social skills and those emotional skills increase. Long term, we want to keep children in their care setting without disruption, and we want to make expulsions a thing of the past. It is our desire to promote healthy environments where children can play, learn, and grow. Next, we want to take a look at our training our training logic model, Our training model. And so again, as we think about our goals, here our goal is really focusing on the education and the support needed to implement effective consultation and effective early childhood programming that aligns with our state's early learning and development standards. Our population and our target audience here are those early learning professionals and consultants that work with at-risk programs. And again, as we think about our outcomes regarding this model, our outcomes when we're looking at training, we want to think about capacity building efforts as being key. Increasing knowledge that will support an enhanced system of young children, for all young children. As we consider those long-term outcomes, we want to develop a qualified workforce of consultants to meet the growing needs of the field. And when working with teachers, we know that when teachers are well equipped, they are better able to effectively teach and support our children. And now finally, our child-focused logic model. When we consider our goals and our population remain the same. We keep healthy social and emotional development at the forefront as an overall goal in supporting the children who are at risk for concerns, for delays, or at risk for adverse experiences. And again, I want to draw your attention to those short-term and long-term outcomes with our child-focused work. And as we think about our short-term outcomes, providing education and support to children and families can create access and opportunity to receive services as early as possible. Again, we know that services are not always available across all of our communities. And so when we can bring those that pieces of information to empower parents, to empower teachers, to intervene early, we know that that is critical. And that leads to our long-term outcomes. Intervening early through consultation is a critical step in disrupting the preschool to prison pipeline. And as we know, research tells us early expulsion in preschool leads to negative outcomes in the school age setting and has a lifetime of impact. We're going to have Dr. Alloy help us connect these logic models into our demonstrated outcomes as she gets into some of our data.
Thank you, Lisa. So as Lisa mentioned, Ohio went through a consultative process to develop our vision. Dr. Deb Perry, who opened our session, was among the group that helped us formulate. And we have partnered with our Georgetown specialists for decades to get to the point that we are now. So I think it's very important to acknowledge that it takes time and planning and resources to be able to develop a system, a statewide system that's consistent. So as Lisa shared, we have our logic models. Ohio has child, classroom, and training-based logic models. We collect data across a few evidence-based practices. Our cornerstone is our partnership with the Devereaux Institute, and that is for our DECA and our DESA, and that is the Devereaux Student Strengths Assessment and the Child Assessment. We also collect data on our ASQ, the Ages and Stages questionnaire. We also collect on the CBCL, which is the Child Behavior Checklist, and we are introducing the child from Yale, the Climate of Healthy Interactions for Learning and Development. And I'm going to speed up so we stay on time, but we're so excited about the child because this is the first tool that we have now to our industry, to our specialty, that allows us to focus on the behaviors of our educators and our caregivers exclusively and shape that in a way that is either undermining, promoting, or at baseline for our social emotional development. And we're just thrilled at the data that's going to come from the child. We've seen a little bit in the initial Yale study. The statistical analyses, so when we developed our program, and this is a footnote for everyone else, we knew at the onset that an external evaluation was going to be a part of it. And so from my mind, I'll never receive money at that level and not be able to say what we did with it. So I want you all to put that on your punch list. So we contracted with an external evaluator to develop this database and now do the analyses. From 2017 to 2013 to today, we have data on over 93,000 little people in Ohio. And the analyses span several types of statistical testing. We do our ANOVAs, our analysis of variance, our ANCOVAs, our analyses of covariance. We do our independent T-tail tests. We look at effect size, and we're just pleased to say that we have reached statistical significance across most of our measures and a moderate effect size as well, which speaks to the replicability of this work, and that is significant. And finally, we receive at the state level a mid-year and an annual report from our evaluator, helping us to know what we do, and we also engage in continuous quality improvement. So here's a quick snapshot. I think what's important to notice on these bars, we're presenting some 2018 and 19 data, is that we again use the DECA as our cornerstone. And so what you see is across the initiative, self-control, and attachment, that we receive results that we know are not by chance and meet the 0.05 level of significance. So we know that within 95% of certainty that these results did not happen by chance. We see that in 2018. We see that in 2019. Next slide, please. We see that in 2020. And even with the pandemic between 2020 and 21, we see the same trend line. So we know that we are working with things that are not chance, that this is now science, and that we were able to orchestrate these types of outcomes. Next slide, please. We're now looking at our data from our parents, and we see that our parents, while a smaller N, are also reporting similar findings, that our pre-test to post-test bars, if you just let your eyes hit on those color bars, that at the end of our intervention, we are seeing increases in the positive things and decreases in the negative things, decreases in behavioral concerns and positive increases in initiative, self-control, and attachment. Our teachers say that, our parents are saying that across our experience. Next slide, please. And I think we have that for 2020. And we think that's really important during the pandemic in 2021. And so that is a very important finding, that the pandemic, we saw increases in behavioral concerns, of course, and we saw problems with attachment and self-control, things you would expect to see with the type of isolation and changes that our society went through. But our work continued, even though we had to pivot to virtual and mainly virtual formats, we were still able to practice the model to fidelity. Next slide, please. Important for Ohio are the retention rates. We are maintaining our children in the classroom. And what I like to say is, where we intervene, we don't intervene in all early learning settings across the state. We don't have that much workforce, but in the programs that we are in, we have high levels of retention in our classrooms consistently. We have some students our services are no longer needed. We have the wonderful matriculation into kindergarten. We have some that are transferred into other early learning environments, which is important for equity because there is not always a goodness of fit. And finally, Ohio is seeing a far below the national average for expulsion. This data comes from Dr. Gilliam's work, the 6.7% preschool expulsion rate nationally. In the programs that Ohio is in, we are retaining over 99% of the children that we come in contact with. We are retaining, I will repeat that, over 99% of the children that receive our service. It is a powerful intervention. It is a powerful specialty. Next slide, please. Finally, I did touch on our program evaluation. We conduct focus groups periodically with our end users to understand if our database is working, where the points of refinement are. And we also do that around the entire state of Ohio. And we want to hear from consultants, supervisors, master trainers, directors, program managers, and clinical staff. How is this database working? I think if I were to give you one other nugget for your bullets, don't be afraid to do self-examination and be open to understanding where things are working well and where things can be improved, because those are opportunities for greatness. With that, I believe it's time to turn over to Dr. Black. Oh, I have to hit the Yale slide. Yale basically found what our program evaluations found is that in the control group, as well as the IECMH service group, the same pre to post test trends continued. And we were thrilled that an external evaluator and a blind study would be able to replicate what we found on our internal data. So we are beyond thrilled that the results turned out this way. And a hidden gem, we also looked at teacher turnover, which Ohio's logic models are yet to really tune into. The Yale study showed that in our control samples, we had high levels of teacher turnover, which is probably our national norm, as we know. But for those programs that received early childhood mental health consultation, turnover rate was down to only 10%, a high impact and a high significance levels. It's in the thousands of a percent. So that's very, very important work that we know this specialty provides. I want to make sure that Dr. Black has plenty of time to talk about our workforce. I think the next slide goes to her. Thank you.
Dr. Black, are you on mute?
We'll give Dr. Black a chance to log in. So in the interest of time, I'll start. Lisa, perhaps you can tickle her and see if we're having a technical problem. Thank you, Dr. Perry. So the next slide talks about our training and workforce expansion. And we are proud to say that as of today, we are registering 105 early childhood mental health credentialed consultants. Our number ranges between 105 and 120 based upon renewals and workforce matters. We also, in our infant early childhood mental health credential, we have the 3 levels that we mentioned, and we have the family affiliate that now has 208 certified folk. We have 235 infant family practitioners. Those are mostly our developmental disability partners. And at the highest tier, reserved for the masters and above, we have 80 Ohio infant mental health practitioners. We also have done significant training. We have provided training in 84 of our 88 counties, which represents an increase over previous years. So we credit COVID and technology to that. And let's see, we are total training participants from fiscal year 17 to 21. We have touched over 59,000 lives.
Dr. Alloy, my computer's on now, so I'm
Perfect.
back
We'll
and I'll
let you
take
take
it
the
from
next
here.
slide. We're ready for the next slide.
Okay, well, first of all, let me just quickly say that I'm really pleased with the opportunity to present with my colleagues on our journey from logic to outcomes. So I'll continue the overview of the training and credentialing process required for infant and early childhood professionals to ensure that they possess the skills, education, experience, training in the core competencies, and appropriate licensure or certification from a state of Ohio board or certifying agency. This is Dr. Black presenting, so if in the spotlight, whomever's covering that, if you could please switch to Dr. Black. Thank you. Now, we are assured that our professionals have the expertise to meet the developmental needs of our infants, toddlers, and preschoolers, and for our caregivers to meet their needs in relationship-based practices to achieve the optimal social, emotional, behavioral development and wellness. As Dr. Alloy stated earlier, we launched in 2009, but I want you to know that 2012 is when we revised the core competencies. And in 2012, when we did that, we grandfathered all those that were already credentialed, and then the new ones had to meet all of our new criteria. So you now see that the first one is our infant and early childhood mental health credential. Hello, is someone managing the video? Is it just me that just cannot see?
That's correct, Dr. Black. You're on screen and the slides are progressing.
I just can't see myself. Oh, okay. Now, the education that's required for the early childhood mental health credential is a bachelor's degree, a master's degree is preferred, and they must have a major field of study related to early childhood. And we really emphasize that. They must be licensed, as I said, by a state board or certifying agencies. What we accept are the LSW, LISW, LPCC, a psychologist, marriage and family therapist, nursing, MD, DO, and under other professional licenses. When there is a question, then the transcript and their experience is sent to central office and we do another review for approval. We have training that's required in the Ohio model of consultation, and that is 12 hours. We have an online 5-hour presentation for renewal. Also, they must have the Devereaux Early Childhood Assessment, the DECA, 12 hours in that. And then in the core competencies, 15 hours. The work experience must be 2 years and 2 years employed by Ohio Department of Mental Health and Addiction Services, certified or partner agency, and currently working with children birth to age 6 and families, or within the past 3 years, they have worked with children birth to age 6. Next slide. Now, here are our core competencies. We have 5: social emotional growth and development, family and community relations, assessment, intervention, cultural and linguistic competency. Next slide, please. The infant mental health credential requirements, which Dr. Alloy shared with you, was launched in 2020. And we have 3 levels of credentialing for the infant mental health credential. And that is the family affiliate is level 1, family practitioner level 2, and the mental health practitioner level 3. So the education requirement for the family affiliate is a high school diploma, GED, or the Child Development Association certification. 2 years infant early childhood work experience and 20 hours required in relationship-based training on social emotional child development, maternal or infant health screening tools. And then for level 2, they have to have the same relationship-based training, but added to that is the trauma evidence-based interventions. And for the mental health practitioner at level 3, they are required to have training in infant mental health neurodevelopment, infant family assessment, and of course, the trauma evidence-based treatment interventions. Now, our reference to supervisory verification that's required, we have included now a requirement for reflective practice, which includes reflective supervision, a reflective self-assessment, or participation in a community of practice during the period, the 2-year period before you're requiring renewal. Next slide, please. Well, let me just close with, because we were asked to include something related to diversity and inclusion, and a critical success factor, which is paramount for effective programmatic service delivery, is to support and strengthen diversity and inclusion in expanding the capacity of our professional workforce. So to facilitate workforce expansion and increase diversity of our workforce, we have adopted a hybrid training model to include online, virtual, synchronous e-learning for the workforce and asynchronous online courses in which one can learn on their own schedule within a time frame. It is because of all the efforts of our state providers, our mental health consultants, our master trainers, our state agency, interagency partners, and the state stakeholders. You know that it is teamwork that makes the dream work. With that, I will now return the presentation to my co-presenter, Dr. Valerie Alloy.
And Dr. Alloy, I just want to let you know that we do have about 7 more minutes left in the session, and we have a few questions that have come in. So just wanted to kind of do a time check with you.
I appreciate that so much, Dr. Perry. This is our last slide. We're just going to talk about the pivots that we made during the pandemic, and let's take those questions next. I'm sure everyone is wondering how the pandemic affected Ohio's service delivery model, and I just want to touch on a couple of the important things that we found. One of the most important was retention of that workforce. And so we allowed flexibility, such as carryover for our funds that weren't expended, and flexibility in our funding models so that no one in our workforce needed to worry about not having a job during the pandemic. Clearly, technology ushered into her rightful place in our life, our human existence. And so a lot of our services were hybrid and mainly remote. We provided opportunities for professional development and credentialing. So there was a lot of training that went on during the pandemic. And then next slide, please. We also provided other toolkits. This is an example of tips for parents during the outbreak. So we made sure that there are resources at the family and community level for parents in particular who are now at the front line of caregiving, as well as at the agency and provider level, that they could continue to provide services however their agencies saw fit for their safety. Would my team be okay if we shifted to the questions now? So if there are any follow-up questions, we have a chance to address. All right, well, let's take our questions, please.
Great, maybe we could take the PowerPoint down and spotlight the 3 presenters from Ohio. So there are a couple of questions. The first one starts with what I just like to also emphasize is you have a very impressive system. is how the question starts. And I think we all agree that you guys have built something that's really, really remarkable and very impactful. And so Lana really wanted to know, is mental health consultation available exclusively in early care and education? And I think one of you spoke to that earlier, that you have expanded now to early intervention and are expanding to primary care. So if you could just sort of clarify that for Lana, who wanted to know kind of where are the services available?
Lisa, why don't you take that one, please?
Sure. Thank you, Lana, for that question. Yes, our primary footprint has been in the early care and education system, working with those brick and mortar childcare programs as our traditional model. But we've really tried to extend our services beyond those traditional classrooms into family-based childcare programs. We have extended our consultation into working directly with home visitors, our early interventionists, and working with our developmental disabilities program. And then, as we discussed in our additional partnerships, we're really focusing our efforts on bridging that gap with the education system and providing consultation to our state support teams. And that is a model that they are also consultants who are working to support the educators, the building administration, district level leaders in their area. And so we work with that team to help support and coordinate efforts to bring that ECMH lens to their work.
Wonderful. Thank you so much, Lisa. The second and third questions are actually sort of the same. And that was really about the outcome measures that you spoke to. I believe Dr. Aloy, you might have been the one who mentioned. So they understood that you were doing the DECA, the Devereaux Early Childhood Assessment. And then you also mentioned the DESA, which is all part of that same Devereaux package. And then there were a couple additional measures that you spoke to, Dr. Aloy. Maybe you could just say that again for Megan, who asked that question.
Megan, when we stood up our program, we looked at a suite of measurements. And so our data system allows us to collect along all of those, but our heavy emphasis on the reporting is around the DECA suite. But we do use the CBCL. There is an opportunity for providers to input pre and post findings on the CBCL. On the ASQ, which our home visitors rely on, so we decided that wasn't as important because we have another state agency tallying results on the ASQ. And we want to add the child is going to be our newest tool in the suite that we're going to build heavily around in Ohio. And I'm just going to turn back to see if I forgot anything. Those are the ones.
Wonderful. Thank you so much, Dr. Aloy. There's another question from Lana, who said that you mentioned developing your own credential and competency. Can you clarify why your state decided not to adopt the Alliance for the Advancement of Infant Mental Health Competency or Endorsement System?
I appreciate that question as one of the main authors in what Ohio did. There were two main considerations. The top consideration was cost. At that time, there was and there still is a hefty price tag on adopting the Alliance model. So there was that. And there was the view at our governor's office that we would rather invest that cost in Ohio to build our own program. The other consideration at that time, and still, is that the Alliance model focuses on what we call Tier 3, mainly the licensed and heavily trained and credentialed mental health professional. And we know that in Ohio, we have significant disparity outcomes, infant mortality outcomes, educational attainment outcomes, that we felt it would be important to build a more transdisciplinary model and the work for infants, the work around infants. So Ohio decided to open our approach for our high school and baccalaureate level or up to associate degree level folk who would be at that end of the spectrum with design trainings and interventions, then encompassing our back up to baccalaureate level folk with the same types of trainings and interventions, and then saving the third tier to the master's level and above professionals, mental health professionals. And we followed a similar suit as we brought up a trauma-informed care training certificate as well. So this is a challenge, I think, to other states on how do you be cross systems and collaborative and transdisciplinary. And if I'm not mistaken, I think the Alliance model is now looking to bring in other levels of professional in their model as well. So we appreciate being a groundbreaker and a ground setter in this work.
Well, I just want to say that we've come to the end of the session. I just want to say on behalf of everyone who joined us, what an incredible job you all did talking about your very complex and very comprehensive approach in Ohio. I know you've inspired a lot of people, and I know that we're all grateful that you were willing to come and share your work with us today. So thank you, Dr. Black, Dr. Alloy, and Lisa for joining us today at the Center for Excellence in Infant and Early Childhood Mental Health Consultation Conference.
Thank you.
Thank you for the opportunity.
Yes, thank you for having us.